Okay, you can start.
Okay, so I have actually got a couple of papers with me because when I started preparing for the first one, it felt like that I'll end up, finishing a presentation very soon. So I prepared another one, and in fact did present it yesterday in the local journal club here. So the first one is it sounds like an audit, and there are no sort of complicated stats or something, but the conclusion was intriguing to me, so I ended up preparing this paper.
Okay.
So so it is, yeah, it's published quite recently in European Journal, and it's about ultrasound features and then classifying the thyroid nodules in confirmed medullary thyroid cancers on various risk stratification systems that are used across the world. So the first thing is that the risk stratification system across, in different societies and that get employed are actually based on the risk against papillary thyroid cancer. So they are not against MTC and not validated against MTC. Now, the other thing is that the preoperative workup, we know that it's quite controversial. Some say do a calcitonin. I think in Italy or in France, there is some debate about doing it preoperatively. The existing data suggests that the ultrasound neck is not very good at identifying MTC, and the FNAC in medullary thyroid cancers is has a low sensitivity. So this is just a refresher for what we use in Britain. So U classification, which does not consider the size criteria per se, but looks more at suspicious features to recommend FNEC or not. And uh, I'll just sort of point out mainly the U3 where if the nodule is hollow or has hypoechogenicity or vascularity, then we recommend doing a FNAC on those nodules. Yeah.
So this is really for papillary, not for medullary. Yeah? This is looking at.
Yes, this is papillary. So there is no ultrasound recommendations for medullary. So it's basically thyroid nodules. And then later on with FNAC, we find out that it turned out to be medullary. Uh, Although, there are different series and studies, which I'll talk about later in the presentation, where some features may be slightly more specific for medullary.
Okay, I'll just tell everybody that U2, there's a lot of papillary cancer, thyroid disease that never kills you, and they're U1, they're U2 and U3, right? And they should be left alone. And medullary is a different ballgame. It's a bad cancer to have, but you don't know that it's rare. So when people have a lump in their neck which counts as U2, we just say don't worry about it, right? That's just a bit of background. Okay.
Yeah, so this is another paper which was actually published from Singapore. But often, I mean, when I was trying to sort of look for studies where they have looked at the performance of BTA guidelines and their classification, I didn't find many. And this is the most recent that I got where they had reasonable numbers to compare against in under different risk stratification systems. And if you see here, so I don't know whether you can see my mouse cursor or not.
Yeah, we can. We can.
Yes. Okay. So if you look at sort of U2 and U3, so in U2, there was 8% malignancy rate in this series, but otherwise the rest of the cancers, which we FNA anyways, were, we were picked up, we know that the malignancy rate is much higher and then U3 onwards, and therefore we FNA them. Uh, Interestingly, the BTA also does not give any recommendations on malignancy rate, which will be acceptable also in at different grades of nodules, whereas others like ATA or thyroid's classification does. The other risk stratification systems that are used are EU, thyroids, ATA, American Association of Clinical Endocrine, American College of Radiology, and Korean thyroids. And they are roughly quite similar. the main difference between them and us is that they use size criteria quite often to FNA certain nodules. So in this paper, this looks very much like an audit that they have been collecting data on for over 5 or 6 years, and then they decided to publish it eventually. And so they have 152 histologically confirmed medullary thyroid cancers, which were operated in a sort of referral tertiary center in Italy, and they excluded all incidental MTCs. So anyone who had surgery for non-MTC reasons and then found out that they had MTC, or those who had preoperative ultrasound evaluation. So maybe if someone had Graves' disease, maybe, or other things where they did the thyroidectomies. Uh, the I know that I think Florian talks about the ultrasound probes and their sensitivity. So that's why I've just mentioned that. And all the ultrasounds are actually done by endocrinologists there, whom they say that have had more than 5 years of experience before they sort of regularly perform ultrasound and the nodules that have been included in the study. And they used both ultrasound reports and imaging to actually pick up the characteristics for different nodules. When there was more than one MTC identified in the thyroid specimen, then they only included the nodule with a larger dimension in the study. And interestingly, they actually, in their own ultrasound reporting methods or system, they do not comment on vascularization there. So they have not included it, but then it's not part of most risk stratification systems, unlike BTA, where we do consider it. So this is the baseline characteristics. So it's just medians or sort of numbers and percentages. And the first thing is that their median age of the people included was 53, and then roughly sort of 20% had red germline mutation in their series. Then if you look at the echogenicity, only sort of 24% were markedly hypoechoic, and some were around 20% were hypoechoic, where there would have been an indication to FNA then. The MTC median diameter in centimeters on ultrasound was 1.3 centimeter, and that was the same in histology as well, so 1.3 centimeter lesion. And if you look at, I think they have just subdivided this echogenicity later on, and then they have said that there were some who were markedly hypoechoic and slightly hypoechoic. The calcifications is another thing, because our U4, U5 particularly, they have microcalcifications in there, but only in less than half the cases. Only around sort of 50% of the cases they had calcifications in their specimens. And they've also considered it sort of taller than wide, because those nodules which have a sort of a more sort of, they are taller than wide in their dimension, have a much higher chance of brewing cancer. And when they looked at, tried to look for some specific features of MTC, they noticed that so the solid nodules were around 93%, and when they added other features into it, the specificity kind of repressed from there, really. So if they consider sort of all four features which are highly suspicious of cancers, then you're looking at 8% of the nodules meeting that criteria. And then the next thing they did basically was try and classify these MTCs according to different risk stratification systems. And that's where they have concluded, really, that that quite a few of those cancers, so around sort of 40 to 50% were either in the intermediate or low category, low suspicion category across various risk stratification systems. And this is quite a busy slide, but the numbers in bold are the ones where they would not have had an indication to undergo FNA. So if the summary of that slide is that across different risk stratification systems, the number ranged from 36% to 51%, which would not have been recommended to have FNA based on that particular risk stratification system, which I felt was quite high. But then uh, so this is like so the next couple of slides are on just to give you some idea of how other risk stratification systems work. So ours is, U3 onwards, we FNA. This is EU thyroids, and that looks at some like echogenicity, or if there are irregular margins, microcalcifications. So they recommend doing an FNA. But if you can see on the last row, if you have no suspicious features, then they start considering the nodule size as well to decide on FNA based on their the risk of malignancy rate. This is American College of Radiology, the classification system, and they used a points-based system where they want you to just add points from each category, and if it meets, if the total score is 3 or more, then FNA is required, but they still consider the size in their classification, in their risk stratification system. So this is what different guidelines recommend in their recommend the acceptable malignancy rate, or like based on the evidence that they had on which they formed those guidelines. And this is what the MTC rate that they found out in across different risk groups. So, for example, like in ATA, quite a few of them had intermediate suspicion, and less than half had high suspicion. And same is true for other risk stratification systems. But there are a few, I mean, are up to around 10%. If you consider all sort of lower grades, which would not have been FNA'd as per their recommendations. So the author's conclusion was that neither single nor combination of ultrasound features are specific for medullary thyroid cancers. And then they further concluded that, the 5 main risk stratification systems only sort of identify less than 50% of the cases. And then they started raising alarm bells that you are risking and potentially missing or delaying a diagnosis of medullary thyroid cancers. And they're concerned that because it has a much higher metastatic potential, it's a much higher risk as compared to PTC, and ultrasound features are not very diagnostic in such case. But then because I kind of went back to the U classification, and then I was like, our U3 has a solid nodule. U3 looks into solid nodules in the criteria. So we might, have actually FNA'd those patients in our system. And therefore, the risk is probably not as bad as what the authors are concluding from Italy. Albeit that we do not recommend doing less than centimeter nodule, and so as ATA and even other risk stratification systems as well. And 34% of the medullary thyroid cancers in this case series is less than a centimeter in size.
What you're saying is that U3 doesn't look at size. If it was U3, you would have done FNA regardless of size. So you wouldn't do it as MTCs.
Yes. See, the other
Exactly.
problem with this is it's retrospective, you're about to say, which means
Yes,
34% sounds really terrible, but that's 34 out of 100, and they've done 10,000 capillaries in the process. So if you start boxing with lots of others, you're going to get a lot of false positives in the capillary group, which is what most people have when they have a lump in their thyroid.
exactly.
Yeah.
Yeah. So I mean that. So I think first it's retrospective is just single center, and they have made some comparisons with other series and some of the feed like irregular margins. This group had very few cancers which had irregular margins, which is like a U5 grading, compared to like a 40 to 50% risk of irregular margins in MTC generally. And they have said that the reason behind that is that the median MTC size in this series is 1.3 centimeter, whereas in other series it's more than 2 centimeter usually, where the nodule might have had enough time to actually develop irregular margins during that time. So that's that. Plus, there is no control group to compare against. And then I think there are other things that they have not included, which is the sort of pre-test probability. If someone has had, RET mutations or like a suspicion of a familial sort of cancer running, then obviously I think we would be more prone to sort of follow them up and maybe repeat an FNA or FNA them even if the findings on the ultrasound may not be that suspicious. So that's the first paper. Then this is like something that I just extracted from our guidelines, UK Management of Thyroid Cancer guidelines, and that's mainly for registrars really. And that's so thyroid cancers are like medullary thyroid cancer is rare, and it constitutes about 1 to 3%, and 25% of the cases are familial, and therefore there is a recommendation to do a RET gene analysis in all MTC patients. FNA is often reported as Thy3 in such a, but calcitonin staining may actually help in diagnosis. And whilst working up for patients with suspected or proven medullary thyroid cancers, we do the usual biomarkers of calcitonin and CEA, but we must also look for FEOs and hyperpara. And then there are recommendations to do imaging studies to guide extent of surgical resection. Post-op calcitonin is most informative after 6 months. The post-op follow-up may require other imaging modalities, but if the calcitonin is less than 400 picograms per mil, then we are unlikely to identify METs through these imaging modalities. Surveillance is lifelong using calcitonin and CEA. And in surgery, and all MTC patients require a total thyroidectomy and a central compartment node clearance. And if there is metastasis or inoperable disease, then tyrosine kinase inhibitors and radiotherapy may help in controlling symptoms. So that's my first paper. I'm happy to take any questions.
Thank you. Any thoughts? This has to get published, isn't it? How to publish all of this? This is the European Journal of Endocrinology.
Yes, I think the main thing, so on the last paper, they have written their disclosures, and the lead author is in the editorial board of European Journal.
Okay.
In 2006, I went to the thyroid
Ultrasound, yeah.
during which I discovered I had 3 nodules.
Oh, you did it? Oh, yourself?
And I had no FNA, no follow-up.
Was it you too?
I don't. Yes.
Okay,
No,
well, that's all right.
yeah, U3,
Okay.
but it's 15 years and I'm done.
I mean, this is the problem. There's no mortality data.
Yeah,
Because
well, the
for
mortality hasn't gone up
papillary,
despite discovering all these.
well, for papillary thyroid cancer, the risk of dying is really, really low. But for medullary, it's really high. So that's the problem. And medullary is
Yeah.
quite rare. Okay, do you want to see the other paper?
So this is a completely unrelated paper, and it's more of an epidemiological study. And so this is published quite recently in Lancet, and it's trying to figure out some ethnicity-specific BMI cutoffs for incident type 2 diabetes risk in England.
Right.
Yeah. So the background to that is that, we know that BMI cutoffs were introduced to define obesity by WHO in 1993, but these were based on studies that were done exclusively in white population, and they considered the mortality association with BMI when formulating those guidelines. But as the evidence started emerging, particularly in South Asians, where we started noticing higher prevalence of diabetes at a lower BMI, the WHO revised their criteria and they said to trigger lifestyle interventions at a BMI of 27.5, and NICE has the same cutoff. And they did consider a fat percentage they use when they revised this. There have been lots of studies. We all know that South Asians have a higher diabetes risk at a lower BMI, but and their previous attempts have had their limitations, and authors have discussed small size of ethnic groups. They mainly use the diabetes prevalence data instead of the incident data, and often the studies have used like surrogate markers instead of an actual diagnosis of diabetes. Uh, so in this study, they used the primary care CPRD data and the hospital episode statistics data, which is the secondary care data. They divided the study participants into 5 ethnic groups. They included everyone who was 18 or above, no prior history of type 2 diabetes, were registered with a GP in England between September 1990 and December 2018, and at least had a year's follow-up available. And they excluded everyone who had a BMI beyond 50 or less than 18, or they had missing ethnicity data, or their ethnic, or they were mixed race. Uh, the exposure, they define exposures as the earliest BMI recorded from the date of GP registration and up to a standard date. And the way they have defined standard date is where that GP's data is considered to be research quality to be entered into the CPRD system. And from the date at which the patient turned 18, so obviously the BMI after that. They excluded everyone, they excluded a 12-month period following the date of the earliest BMI so that they avoid reverse causality, they avoid some, like if they have calculated, if they had, BMI recorded closer to the actual diagnosis of diabetes, that then it might have affected the results, like people may have taken some weight control, weight loss measures, or it may not be truly incident. And after that, they calculated predicted age and sex adjusted incidence of diabetes, first in whites at a BMI of 30. Then they repeated the same analysis in other ethnicities. And then they repeated analysis at a BMI of 25 because that's the BMI cutoff for overweight in whites. And how did they identify the type 2 diabetes patients in their study? And they used what we call like a caliber algorithm, and this is actually designed by UCL Health Informatics team, which uses coding data from the GP practices as well as from the hospitals, and then they tried to filter all sort of uncertain, suspicious cases so that the data is more reliable for the type 2 diabetes diagnosis. But we all know that there are issues with coding both in primary and secondary care, because we may use HbA1c, we may use other features. But this algorithm, according to the authors, is validated, and it's actually being used to phenotype other diseases as well. So in this study, they looked into 2.2 million individuals, and then after exclusions, they included 1.47 million. And these are the real highlights of the paper. 97,000 were diagnosed with type 2 diabetes over a median follow-up of 6.5 years. And at a BMI cutoff in whites of 30 kilogram per meter square, the equivalent BMI cutoffs where your diabetes incident is similar to what whites have at 30. The cutoff in South Asians is 23.9, which I believe I found quite low. Then blacks 28.1, Chinese 26.9, and Arabs 26.6. And that's the baseline characteristics of the population. They've just looked into sort of smoking status and an index of multiple deprivation. And most of the participants are whites, but there are reasonable number of South Asians and other ethnicities except Arabs, which I thought were quite low in number compared to 1.3 million whites.
So 75,000 South Asians.
75,000 South Asians, yes. Again, quite a big difference compared to whites, but then, yeah. So this is what I said earlier, really. So this is where the risk equivalent to the risk in whites at 30 kilogram per meter square, the BMI cutoff in South Asians falls at 23.9 and in Arabs at 26.6. The when they what they have done in the is then they have looked particularly into South Asians a bit more, and then they found that the people from Bangladesh were actually doing like the worst amongst the group, and the Pakistanis were at 23.5, Indians were at 24.3. Interestingly, my own BMI is actually 23.5, so I'm just there. Yeah. And then they repeated the analysis at a BMI of 25 in whites, and then looked at the BMI cutoffs in others, and it falls at a BMI of 19.2 in South Asians. So they're at quite a disadvantaged position, I think. And this is, so the first three graphs were age and sex adjusted only. And this is also adjusted for index for multiple, for deprivation as well as for smoking. And I couldn't really explain it very well. It seems like that those two had a protective effect somehow cumulatively, because the BMI actually falls from 23.9 to 23.3 for South Asians as a cutoff. I mean, they haven't really commented on why on this graph. It's a supplementary graph, but I felt it was interesting to discuss. And in the discussion, they've discussed potential reasons, so body composition, lifestyle factors, biochemical characteristics, and genetics. And this is from another paper which was published last year in Diabetologia, where they have proposed some hypothesis which they feel that requires exploring. So they felt that in South Asians, their beta cell function is much worse, even in euglycemic non-diabetic individuals, and they have a lower lean mass compared to other ethnicities. So they produce less insulin than other ethnicities. Plus, they have less lean mass. So, and a super added insult of sort of lifestyle leads to more fat deposition in liver and muscle, increasing insulin resistance, and therefore predisposes them to an increased risk of type 2 diabetes at a much lower BMI. So they have concluded that this data is quite compelling to shift the goalpost and move the BMI cutoffs for minority ethnics from 27.5 to using ethnicity specific BMI cutoffs, so that the access to the weight management services is triggered much early, and it gives you a much higher, much sooner opportunity to screen for diabetes, because we may be able to find diabetes early, and then it gives you a chance to look at diabetes remission interventions as well. So the strengths of the paper is, obviously it's a large sample size. They have tried to subgroup the ethnicities quite well, I think. Then they said that there is a validated algorithm for type 2 diagnosis, and use the truly incident data uh, for in their methods. The limitations, the BMI may not be representative of other nations in UK, and this BMI cutoff is particularly specifically for diabetes incident risk, and not for cardiovascular disease risk or mortality. That's where I conclude this one.
Yeah, thank you very much. That's a bit worrying, isn't it? But